Good afternoon. This is Dr. Subhanshu from the Department of Orthopedics. I'm an assistant professor in the Department of Orthopedics. I cater to patients that belong to the trauma category, to spine and joint replacement. Today I'm going to be taking you through a presentation of spondylolisthesis. Spondylolisthesis is a condition whereby the vertebral column shifts ahead from the rest of the sacrum. Okay, it can happen at the lumbar level or at the sacral level. I recently did a case of spondylolisthesis grade 3, sorry, and I will be talking about that too. Okay, so spondylolisthesis. Spondylolisthesis is basically a condition in which the pars interarticularis, which is a joint at the level of the posterior elements of the vertebra, that is deficient. It can happen due to many reasons. One of the reasons is congenital, which is called dysplastic spondylolisthesis. The other ones are traumatic. It can happen due to trauma. Pars interarticularis is the space where the pedicle, the facet joints and the transverse process meet. So when there's a deficiency there, the vertebral body goes ahead and shifts ahead with all of the aligning vertebrae above it. So it goes anteriorly and the sacrum along with the pelvis remains posterior. Between the bodies and the posterior elements lies the spinal cord. So due to this condition, there is some pressure on the spinal cord. Due to the translation of the whole vertebral column anteriorly, there will be some pressure on the spinal cord, and according to that pressure and according to the roots that are compressed, the patient will have symptoms. The first symptom normally to basically appear is mechanical back pain. That is happening because of the spasm of the paraspinal muscles. The spinal muscles will go into spasm in order to protect the vertebral column from shifting ahead. So they go into tension in order to keep the alignment of the spine. But eventually, as the patient keeps on doing his day-to-day life and the spondylolisthesis progresses from grade 1 to 4, then that's where the symptoms start to happen. So what are the grades of spondylolisthesis? So grade 1 of spondylolisthesis is more than 25% translation of the vertebral alignment from the junction. When it's 25 to 50%, it's grade 2. When it's 50 to 75%, it's grade 3, and more than 75 is grade 4. So we recently corrected a grade 3 spondylolisthesis, which was a very difficult case. She was like a 27-year-old lady who had been experiencing mechanical back pain since the past 2 years or 3 years. Her variety of spondylolisthesis was the degenerative type. So basically there are like 4 types of spondylolisthesis. The first one is dysplastic or congenital. It's people who are born with a pars defect. The second one is traumatic. So somebody goes through a trauma and that part of the pars goes through a fracture and then there's a vertebral shift anteriorly. The third one is degenerative. The degenerative one is the most common. Okay, so the degenerative ones normally happen in patients of osteoporosis due to wrong posture, overweight. The mechanical axis which passes through the S2 shifts from the S2 to L5S1. When it shifts from the L2 to L5S1, which is basically the mechanical axis is the most weight bearing part. When it shifts to L5S1, the L5 will glide anteriorly over S1, and that's a degenerative. It takes time to do that. And the last one is iatrogenic. So suppose somebody had a spine operation and intraoperatively there was a fracture. So that can lead to spondylolisthesis. Okay. So let's go into what happens during a spondylolisthesis. So during a spondylolisthesis, we all know that the spinal cord is suspended into the vertebral canal by the ligamentum denticulum. It is not attached, it is suspended. So when the spinal cord is suspended and the whole vertebral column through which the spinal cord is passing through, it shifts anteriorly, there will happen some pressure on the spinal cord and the roots. So whenever there will be pressure on the spinal cord and the roots, the patient will experience symptoms. The most common site of spondylolisthesis is L5S1 and in the lumbar vertebrae. Why? Because there is a lumbar lordosis and maximum weight is borne by the lumbosacral vertebrae coming from all the body above. So once that happens, the spinal cord will be compressed. Patient might have sciatica, pain radiating from the lower back going down all the way to the legs. Patient might have insensate legs, depending on the nerve root that is compressed. The patient will have numbness and tingling in the legs, and there can also be loss of power. If not corrected in time, it could also lead to various symptoms due to complete compression of spinal cord. There can be a loss of bowel and bladder habits. They could, if the compression level is above at the dorsal-lumbar junction, there could also be a foot drop. So a spondylolisthesis needs to be corrected accordingly. Okay. So what investigations we need? So the first investigation we need is an X-ray. In X-ray, it becomes very evident that the patient has spondylolisthesis. Okay. Then we go for an MRI, and patient typically complains of symptoms which kind of overlap with nerve root compression, which would also be due to disc. But how do we differentiate spondylolisthesis from a PIVD, which is a protrusion of intervertebral disc? The way you differentiate is that in PIVD, the patient normally extends and walks, and on bending down, the patient kind of feels pain. Alright. Whereas in spondylolisthesis, if the patient extends, the pain will be exaggerated. On bending down, he gets relief. Also in uphill walking, he will get relief if there is a spondylolisthesis. The second investigation we get is obviously an MRI to assess the diameter of the canal, how much we need to reduce it for the patient to get relief of symptoms, and if there is any root compression. Alright. Okay, so two things are of importance in spondylolisthesis. One is the sacral angle, and the second is the pelvic incidence. These I'm not going to get into the details of this. This is more advanced, but basically on this basis, on calculating the pelvic index and the sacral slope, we know in which directions our screws are going to be placed, and how much do we need to distract, followed by pulling in the vertebral column. So how do we treat this? So treatment of spondylolisthesis, basically whichever vertebra has shifted ahead, we will leave that vertebra intact. We will go to one vertebral level above that vertebra. We will insert two pedicle screws in that vertebra, and then we will come down to the level of the vertebra which has not gone into listhesis, and we'll fix one or two screws there. Okay, once that is done, we'll pass a rod through the screws and we will distract it. Once you distract it, the vertebral column that has gone ahead, it gets some space. Once it gets some space, we put two reduction screws. So basically, reduction screws are screws which are longer than normal screws. So it has the capacity to pull up the vertebra. Okay. So we will insert our reduction screws in the vertebra which is protruded most anteriorly. Okay. So for example, if L4 has gone into listhesis, we'll put two screws in L3, two screws in L5, and two screws in sacrum. Okay. We will distract, some of the part of L4 will come up, and the moment it comes up, we'll put the other two screws in L4, the reduction screws, and we will tighten the innie which is on top of the reduction screw. That will pull the vertebra down. Once that is done, we will fix the lumbar and sacral region with pedicle screws with the help of rods. Now, in severe cases, which is grade 3 or more, we also need to fuse the vertebral bodies. For that, we do a procedure called PLIF or TLIF, which is PLIF stands for posterior lumbar interbody fusion, and TLIF stands for transverse lumbar interbody fusion. So we will be doing these two procedures. Basically what we do in PLIF is we kind of retract the spinal cord to one side. We go between the two vertebrae, take out the disc, make a small rent, take out the disc, then we curate the vertebral body above and below, and after that we insert a banana cage or any kind of cage. So a cage is like a metal hollow device which has bone graft inside, and it can be impacted or hammered between two vertebral bodies. Since it has bone inside, which is a bone graft, it will cause fusion between the vertebrae above and below, and after we're done impacting it with the right size cage which snugly fits, we will then compress the vertebra a bit so the cage gets stuck. Over time, the pedicle screws have given it stability, and the cage has given it some stability, and the graft will unite the vertebral body above to below, and that happens, that causes fusion. So this is like a PLIF. In a TLIF, the transverse lumbar interbody fusion, the transverse process, we fuse the transverse process through bone grafts, either using a burr we can decorticate the bone and put some bone graft there. Bone grafts can be taken from the spinous process we have used to decompress. Okay. After we're done this, we will also make sure that the cord is free. If it's not, we will decompress it to attain a suitable level of decompression so that patient does not have any more symptoms. So post-operative care. So basically in post-operative care, we put the patient on a dorsolumbar or lumbosacral bed. The patient advised bed rest for 6 weeks. After 6 weeks, gradual weight loading is started, and the patient is taught to bend forward and sit up on the bed. He can go to the toilet using a walker and some support. Normally, once you fuse it properly, recurrences never happen in spondylolisthesis, but sometimes it may. That's called a failed back syndrome. In that case, all the devices have to be removed and new fusions have to be done. So that's what I'll talk about spondylolisthesis. It's a short class, the topic is very long, but this is basically what it is. So thank you and good afternoon.